Hello, everybody. Back again. I'm going to do Chapter 8. Chapter 8 is our anti-infective, antibacterial drug chapter. Now, this is a very serious chapter. You guys really have to focus on this chapter and the following chapter. This is where people do not too well on. So start to focus and start listening to what I have to say. If I say it's important, definitely remember it's important, okay? And this is all starting what I say on page 114 of the book, okay? So antibiotics treat bacterial infections, okay? So antibiotics treat bacterial infections, and we know that microorganisms invade the body. They can cause disease or infection. This can lead to sepsis. It can lead to death. It's not uncommon to see an increased temperature as well as an increased red blood cells, redness at wounds, or even drainage. These things should improve when you're on an antibiotic. So when you have an infection, you can see an increased temperature, like I said, red blood cells, the redness or drainage if you have a wound. But when you're on antibiotics, you want to see things changing. So you want to see decreased redness. You may want to see decreased drainage or the drainage looking better. You want to see the white blood cell count in that 5 to 10,000 range. You want to see the temperature decreasing or at a normal range. So those are what you want to see when you're taking antibiotics. You want to see an improvement with why you're taking it. Body, we have to remember, has normal flora, okay, that hangs out, and it's on the inside of our bodies. It's on the outside too. We can find them on our skin. It's in our mucous membranes, and it's in our GI tract. Under normal circumstances, they don't cause a problem or disease. Okay, we don't have any issues. The body can maintain it. It has no problems. They are harmless, but they are beneficial to the areas located. They can inhibit growth of pathogens, but if introduced to another area, it may cause an infection. So if they maintain in their own area, they don't get spread out to places they're not supposed to be, then we're okay. Our body is able, like I said, to keep them under control normally. The problem happens to the normal flora is when we start taking antibiotics. Antibiotics will they will disrupt this normal flora, and it can lead to overgrowth of these species. Example, Candida. Candida occurs when the bacterial flora are decreased due to antibiotic use. Okay, and we know Candida is a yeast infection, right? And a lot of people who take antibiotics have to take something for yeast to prevent them from getting that yeast. So that is not uncommon. Normal flora, if it gets out of control with antibiotics, it can cause an infection, a yeast infection. Now, opportunistic bacteria, this is caused when a disease and tissue damage in people with impaired immune systems. So if they have an impaired immune system, then they can get an opportunistic disease or a bacteria. Now, virulence of a bacteria, that's how strong a bacteria is and how well it can invade a normal immune system. The higher the virulence, the more that you're going to have an invasion. The lower the virulence, the less likely to invade. And if there's an invasion, it's going to be low. Now, we do have gram-positive and gram-negative bacterias. Gram-positive, how they know it's positive is when they stain the bacteria, there's actually a change in the color when the dye is applied. These ones are less virulent and easier to kill or control. Okay, so gram-positive, it will stain, and these ones are less virulent and they can be killed easily. Now, our gram-negatives, they don't change color. They're more virulent. They're harder to kill or control because they have a protective capsule on them. So that's why they don't change color. So we have more issues with gram-negative than we do have gram-positives. Now, when we talk about antibacterial drugs, when we say bactericidal drugs, these are drugs that will kill the bacteria directly. It's going to kill the bacteria, bactericidal drugs. Now, bacteriostatic drugs, those on the other hand prevent the bacteria from reproducing, which allows the body's white blood cells and antibodies to go after that bacteria and kill it. So bactericidal kills the bacteria, bacteriostatic alters the reproductive system, which is going to allow the white blood cells and the immune system to attack that bacteria and get rid of it. Now, when we're talking about different type of antibiotics, they have different types. We have narrow and extended and broad. Now, narrow spectrum antibiotics works on only a few types of bacteria. When we talk about extended spectrum antibiotic, these work on more than the narrow, but the broad spectrum antibiotics works on a wide variety of bacteria, positive and negative. So the majority of the time, when we do not know what the bacteria is, the doctor will order a broad spectrum antibiotic until they can find out what bacteria is growing by doing a culture. And once they get that culture, then they can go for more for a narrow or extended, which is going to take care of that bacteria. But at the beginning, they'll probably do a broad spectrum, which will cover everything, unless they exactly know what the bacteria is that is growing, and then they can do more narrow and extended. It's very important for us to identify bacteria so we know the correct antibiotic to give. And how do we do that? We can do cultures. We can do blood cultures, and we want to make sure we do the blood cultures or maybe a wound culture. We can do a swab of the throat, a throat culture. So we can do different types of cultures, but we want to make sure that we obtain those cultures before we give the antibiotic. Okay, because that can change the culture itself. Another thing we can do beside cultures is get a culture, but with a sensitivity. Now, when we talk about the culture and sensitivity, the culture is going to tell us what the bacteria is. The sensitivity is going to tell us what type of antibiotic is going to work on it. So what they do is they swab a wound and they put it on a petri dish and they smear it around. And the first thing they do is they're going to identify what the bacteria is by doing the culture part. Now, the sensitivity part is what they do is they have these little discs that have like little medications on them, different types of medications. And what they'll do is they'll put those discs inside that petri dish on top of the antibiotic, and they watch to see if the bacteria goes away from it or if it doesn't. If it goes away from it, then we know that's going to be the drug of choice. If it keeps growing on it, we know that medication is not going to help it. Usually it takes about 24 to 48 hours to get results. And it's a way to identify the bacteria and what antibiotic we should use. So it's very important to obtain, like I said, any culture before we start any antibiotic because it will alter the test. Now there's different types of generations. They have generations 1 through 5. And the use of these antibiotics are usually for penicillins and cephalosporins. And it just depends on how well they work on certain bacteria of the antibiotic. The antibiotic will work on the bacteria. Like the first generations are good for gram positives, but not work well for gram negatives. Our second generation is good for gram positives, but a little better for gram negatives coverage than the first generation. The third generation, less active against gram positive, but more potent against the gram negative. And remember, we know gram negatives are the ones that are harder to kill. The fourth generation, that's a broader spectrum of antibacterial activity than the third generation, and it works especially good against those gram-positive bacteria. And the fifth generation, those are the ones that we're going to use for those extended spectrum antibiotics, like to help with those things like MRSA. So those would be the fifth generation. So that's when you hear about generations, that's basically what they're talking about when they say that we're going to use like a fifth generation, a first generation of an antibiotic. Now, when we're talking about side effects of antibiotics, they can cause a lot of GI upset. They can cause diarrhea because remember, it's killing that normal flora, which helps with the digestion of food. When we kill the normal flora, it will decrease food digestion and it will make it move out quickly out of the system in a liquid form. That's why it's very important to ask the patient about their bowel movements. And I mean, it's very important when they're on antibiotics to make sure you ask the patient about their bowel movements. I mean, maybe you should ask them about their bowel movements, like really, really ask them about their bowel movements. Because that's very important to ask about the bowel movements. I don't know how many times I have to say it, but ask them about their bowel movements when they're on any type of antibiotics because you want to know if they're having diarrhea. Another thing is yeast infections. We talked about that because that's also, you can get yeast infections of the mouth or you can get it of the vaginal area. It can occur. And this is usually the antibiotic will kill the normal flora and the fungi or yeast can take over. Okay, in the mouth, it's called thrush. We want to make sure we teach our patients who have thrush to do good oral hygiene. We want them to brush their teeth, use a lot of mouthwashes. Now, when it comes to the vaginal area, that yeast infection, a lot of times the woman will complain of itchiness and a white, cheesy discharge that comes out. We also have to remember men can get yeast infections also. They can also pass, the yeast infection off to the partner. Okay, so if one of the partners have a yeast infection and you have sexual intercourse, then the other person can experience signs and symptoms of yeast infection and will need treatment. So usually what happens is anybody who gets yeast infections with antibiotics because it kills that normal flora, they will always prescribe them diflucan to take. And usually you just tell them I'm prone to getting yeast infections, and they will prescribe medication to help with that. Now, adverse of antibiotics, and we'll be talking about that in the next chapter. Now, adverse effects of antibiotics, severe allergic reactions and anaphylactic reactions. If you take oral form, you may get a rash, and this can happen days after starting the antibiotic. But usually IV antibiotics, that's when you're going to see the allergic reaction will be fast and actually can cause death. Usually you'll see it start happening within about good 15 minutes of taking it. So that's what we have to watch for. And those IV antibiotics, besides causing the anaphylactic, difficulty breathing, vascular collapse, it can cause shock and death, so we have to be very cautious with that. Another complication of antibiotic therapy is Pseudomonas colitis, pseudomembranous colitis, which is also known as antibiotic-associated colitis or necrotizing colitis. And this is an adverse reaction that can occur. Okay, it is something that you got to be very cautious. It's a severe inflammation. It happens in the large intestine, and it's usually due to antibiotic therapy. It can cause an overgrowth of the intestinal organism, and we already know that organism C. diff, which is also known as Clostridium difficile. This organism is not able to be killed by most antibiotics. It takes over when normal flora is killed off by the antibiotic, and it releases a toxin that will actually damage the intestine. The lining of the intestines become raw and they bleed. Other symptoms, they have very bad watery diarrhea, and anybody who's taking care of someone with C. diff, they do not forget the smell of C. diff and the look of C. diff. It can cause a lot of abdominal cramping. They always have that urge to have a bowel movement. They can have a low-grade fever. They have bloody stools. They can become dehydrated very quickly, so we have to monitor that. They should stop the antibiotic, and of course, any antibiotics that can cause C. diff. So that's the bad part about it. But it's that overgrowth in the intestinal organism called C. diff. It's that antibiotic-associated colitis, which is necrotizing colitis, that we do have to watch for. It's that pseudomembranous colitis. Those are the different names for it, but it is C. diff, and it is not very good. But that's what happens. So with these, so adverse side effects, diarrhea and yeast infection. Adverse effects, severe allergic reactions and anaphylactic reactions. You can have some rashes with oral antibiotic after starting in a few days. IVs, anaphylactic, difficulties breathing, vascular collapse, shock and death. And of course, the big complication is a pseudomembranous colitis, which is also we know as C. diff. So before we give any antibiotic, we're going to ask, are you allergic to anything? Do you have any allergies? We may have to give them diphenhydramine or Benadryl or epinephrine if the doctor wants a certain antibiotic given and they have had some allergic reactions or side effects or adverse effects to try to reduce them, if that is the only antibiotic of choice for that organism. We want to make sure we obtain a culture and sensitivity before we start any antibiotic. We want to make sure we get a baseline white blood cell count, because some antibacterial drugs will suppress the growth of the white blood cell in the bone marrow. So that's why we need to know what their white blood cell count is normally first. Check vital signs, especially a temperature, because that's going to tell us about infection. And we need to know their mental status, because some of these medications can cause issue with the mental status part of them. IV antibiotics, we're going to always interact with other drugs. We want to make sure we check that. So if they're getting IV antibiotics and they have other fluids or drugs hanging, we want to make sure those antibiotics are compatible. And fuse per recommendations. We want to make sure that the IV site is good, that there's no irritation around the tissue or having any issues. Afterwards, we want to monitor their bowel movements. We want to ask them, how are your bowel movements? Because we're concerned about diarrhea. IV checks for any signs of any allergic reactions, because the first dose is going to happen at least within 15 minutes. We're looking for hives at the IV site. We're looking for signs of hypotension, rapid irregular pulses, swelling to the lips or lower face, and we know that is called angioedema. So whenever they have swelling to the lips, lower face, feeling a lump in the throat, those are things that we need to stop the infusion from the line. Never take the line out, just stop the medication from infusing. And we always want to make sure we check that IV site too for any signs of phlebitis, which is an irritation to the vein and tissues. We want to make sure afterwards we check and see if the antibiotic is working. Are we seeing a decreased sign of infection? No fever, no chills, white blood cells coming to a normal level. Wound looks pretty good. It's smelling a little better, the drainage. And we're looking for signs also of thrush all the time. We're looking for that white cottage cheese coating on the gums, the roof of the mouth, inside the cheek or the tongue. If that is occurring, we can get them some mouth stuff to use to swish. Good oral hygiene, brushing and using the rinses. Teach patients, make sure they take the entire dose of the medication and try to spread it out over 24 hours. If they're supposed to take it twice a day, try to teach them to take it every 12 hours. If it's 3 times a day, tell them to try to take it every 8 hours. And if it's 4 times a day, try to tell them to take it every 6 hours. Just to try to spread it out every 24 hours to keep a nice level in the bloodstream. Rashes or hives, we may stop the med and we may want to call a doctor. Call 911, 911, I put too many ones in there, 911 for the problem with breathing, or if you're feeling like there's a lump in the throat, because we know that's angioedema and that's very serious and we can actually shut the airway off. So let's talk about different types of antibiotics that we're going to. There are 4 types, table 8.1, page 118 and 119 we're going to go to. Okay, these are all the different types of antibiotics that we have. We have the cell wall synthesis inhibitors. We have the protein synthesis inhibitors. We have the metabolism inhibitors and the DNA synthesis inhibitors. These drugs, read up on them, these medications, these antibiotics work on the cells in different ways. They affect their protein, their metabolism, the DNA, and they affect the cell walls. So that's how they determine which organism is going to work best for that antibiotic. Okay, so we're going to talk about the first one. We're going to talk about the cell wall synthesis inhibitors, which will be our penicillins, our cephalosporins, and of course other cell wall synthesis. These are the first antibiotic was penicillin. We know it was made from bread mold. Today some are made from the mold and others are made from chemicals. This category includes penicillin, cephalosporins, carbapenems, monobactrums, and vancomycin. This is the category. Like I said, you need to know these things because this is important chapters. These antibiotics only work on the bacteria with cell walls. Okay, they kill bacteria by preventing them from forming strong protective cell walls. That's how they're going to work on it. Most effective against bacteria that divide rapidly. So things that are found on the skin, the mucous membranes, respiratory tract infections, ear, bone, and blood. So these are going to work really good on those. They prescribe these antibiotics for strep throat, tonsillitis, otitis media, simple UTIs, wound infections, upper and lower respiratory infections, prostatitis, gonorrhea, sepsis, and Lyme disease. And I would not ask you what ones they're going to cover, but that is some of the things they will use them for. They are more powerful drugs. Our more powerful drugs are the carbapenems and the vancomycin, which are used for sepsis, endocarditis, many abscesses, and multiple types of bacterial infections. Sometimes the antibiotics will be combined to help increase the effectiveness against certain bacteria. So penicillin and cephalosporins are going to be the ones that are mostly prescribed. Monobactrums, carbapenems, and vancomycins are your very powerful and less prescribed drugs. So on page 121, Let's go over common for cell. And now you can see your penicillins are going to be the ones that we use a lot. And if you notice, they end in the cillins. And these are the ones that we do a lot of antibiotics for. On the following page, with the cephalosporins. Now with the cephalosporins, even though sometimes they do have a little bit of, if you're allergy to penicillin, a lot of times they can give you cephalosporins, even though sometimes they do cause allergic reactions for people with penicillins. But it's okay to give if you're allergic to penicillin, even though it has a little bit of the property of penicillin. So with this one, we give a lot of those. We do give the cefazolin, which is Ancep, Cefdinir, which is Omnicep, ceftriaxone, which is Rocephin, and cephalaxine, which is Keflex. Those are all 4 of the cephalosporins we give lots and lots of. Not too much of the Monobacterium. I have not given that one anything. And not much of the, I have given the carbapenems, especially ertapenem, which is advanced. That is probably the only one I've given on that one. And of course, vancomycin, that is a big, big drug that we give, especially when we have septic patients. Usually we will give them a cephalosporin, which is usually the, what do we give? Ceftriaxone, and then we will give vancomycin. Those are usually our 2 drugs of choice that we give for people who are septic. That is a big one. Side effects for these drugs, you can see them on those pages. They're going to be in different categories. Fewer side effects because the human cells have no walls, so these drugs don't target them. So penicillin, most likely to have allergic reactions. You have a lot of people who say I'm allergic to penicillin. More powerful meds like vancomycin have more side effects like nausea, vomiting, fever, chills. You can have pain at the IV site, decreased hearing, decreased kidney function, and red man syndrome. Red man syndrome is a rash and redness to the face, neck, upper chest, upper back, and arms. It's kind of like vasodilatation, so they turn a little red. It is a side effect. It's not an adverse effect. So a lot of times it's usually due to someone infusing the antibiotic too quickly into the individual. It does not mean that they're allergic to it. It just means that probably the antibiotic was ran in too fast, and it causes a red man syndrome. And that happens with vancomycin. Now, penicillin and cephalosporins can cause diarrhea and itchiness. Your carbapenems and vancomycin, of course, you can always have IV site reactions. Those are the ones that are going to cause the decreased kidney function as well as decreased hearing, and that's important to know. Adverse effects, on the other hand, your carbapenems can cause confusion and seizures. That's why it's important to know the patient's mental status beforehand, because due to the carbapenems. Cephalosporins, carbapenems, and vancomycins can cause reduced kidney function. Usually we treat with 2 or more antibiotics. If you do that, you're going to increase the risk for kidney damage or failure. So that's why it's very important to infuse them at the appropriate time frames that they tell you to, not any more, not any less. So before we give any of these cell wall synthesis inhibitors, we're going to ask if they have any allergies. Cephalosporins should be taken 1 hour before or 4 hours after a dose of iron or antacid, because it will poorly they're absorbed if taken together. So cephalosporin, you take it 1 hour before the iron or antibiotic, or 4 hours after the iron or antibiotic, or antacid, iron or antacid. So that's cephalosporins. If you're given penicillin IV, make sure you can be given that route, because there's some that are procaine penicillin. Caine's an anesthetic that is milky white, and you can never ever give that IV. It's usually given IM. If you have a history of seizures, carbapenems can lower the seizure threshold. That means you can actually cause a seizure if you're on carbapenems. So a lot of times if they are on carbapenems for a period of time, they may increase their seizure medication to help with that. Vancomycin given IV, you can't run it fast. Remember, if you run it fast, it can cause low blood pressure and that red man syndrome, and it can cause cardiac dysrhythmias. It's very, very toxic to the ears and kidneys, and you have to infuse it over at least 60 minutes. So what do you do after you give the cell wall synthesis inhibitors? Check for signs of allergic reactions, especially after you give the first dose. Teach the patient about cell wall synthesis inhibitors like cephalosporins. Take at least 1 hour before or 4 hours after antacids or iron. The liquid form, keep tightly closed and refrigerate. Shake well before you give these medications. Pediatric population, amoxicillin is mostly commonly prescribed for ear infections. Their more powerful forms are used for serious infections or if they have allergic reaction to penicillin. Pregnant or breastfeeding population, low risk for birth defects. More powerful forms have low to moderate risk for birth defects. It does pass through breast milk, so it can cause the infant to develop allergies, so that it can occur. So mothers should stop breastfeeding until the medication is finished because we don't want to have the allergies that happen with the medication for the baby. Now, our older population, carbapenems and vancomycin are very ototoxic. Hearing problems is big time, and a lot of older people already have hearing problems. It can make it worse. It's also very nephrotoxic, so is kidney problems. And we know as people get older, kidney functions go down. So we have to make sure when given in higher doses or taken for many days, it can cause hearing problems or kidney problems. They can get ringing in the ear, which is tinnitus, and that means decreased in hearing. Also, we need to monitor their eyes and nose daily to watch their kidney functions. So that is your cell wall synthesis and antibiotics inhibitors. Now, the second one we're going to talk about is our aminoglycosides, our macrolides, our tetracyclines, and other protein synthesis inhibitors. And these ones actually work on the protein of the bacteria to prevent reproduction of the cell, and it causes their death because of that on the bacteria. We can give them IV or IM. They're used for burns, central nervous system infections, joint and bone infections, abdominal infections, peritonitis, sepsis. Streptomycin is usually used to treat tuberculosis. So on page 124 in our books, you can see the different ones for these. And let's go through. For the common aminoglycoside, we use gentamicin, which is probably the biggest one. We use gentamicin, and it's just gentamicin for us. Streptomycin, that's for tuberculosis. So that's one for, we're going to talk about aminoglycoside right now. All right, common aminoglycosides. Now for the common macrolide, on the other hand, when we get to that one, when it's common macrolide, azithromycin or Zithromax, the Z-Pack, if anyone knew about that. Clarithromycin, which is Biaxin, and erythromycin, which is emycin. We use all those. And tetracycline, doxycycline is the big one, and tetracycline is the other two that we use a lot of. So those are usually the drugs out of that list that we use majority of the time. And then the other protein synthesis inhibitors, clindamycin, cleocin, we do give that a lot of times, and usually in pill form we'll give that one. And linezolide, Zybox, we do that, but that's usually very, very rare occurrence. We'll give that one. All right, so those are the doses for the different antibiotics that we're going to be talking about for the protein synthesis inhibitors. When we talk about macrolides, they can be bacteriostatic and bactericidal. They have extended to broad spectrum effects. They treat skin, mucus, and soft tissue infections, chlamydia, and respiratory infections. We do prescribe them for people who are allergic to penicillin or cephalosporins. They are used for Legionnaire's disease, which is a form of pneumonia that people breathe in, bacteria, Legionella. Diphtheria, which can cause infection of the nose and throat, and mycobacterial infections like types of germs that cause TB, some that are found in water or soil, leprosy, so they can be used for those. Tetracycline can be used for gram-negative and gram-positive bacteria. They can be bacteriostatic. They are broad-spectrum drugs. They are used for people allergic also to penicillin or cephalosporins. They do treat acne, UTI, skin and mucous membrane infections, STDs, gonorrhea, syphilis, upper and lower respiratory infections, Rocky Mountain spotted fever, which is caused by a tick, Lyme disease, which is also caused by a tick, typhoid fever, which is spread by contaminated food or water, anthrax. So those are the different ones. And we already talked about the common ones for those. Lincosamides, examples of that would be clindamycin, works well on gram-negative aerobic, which needs air organisms, and gram-positive and gram-negative anaerobic, they don't need air. Usually bacteriostatic, they used are against staphylococci and enterococci, but in higher doses can be bactericidal against streptococci. And remember, I'm not going to ask you which one is going to be bacteriostatic or bactericidal. I'm not going to ask you what is going to kill a upper respiratory infection. These are just for your knowledge base. Oxazolinanines, those are bactericidal and bacteriostatic. Linezolid or Zyvox, they treat serious or life-threatening infections caused by gram-positive microorganisms. They're used for VRE, MRSA bacteria. Not used to treat gram-negative infections, but those are some that we do. Now, streptogramins, they're made up of 2 different antibiotics. They treat serious or life-threatening infections of VRE or MRSA, and you can see the dose on page 126. The side effects for these medications of protein synthesis inhibitors, for the aminoglycosides, you can have nausea, vomiting, rash, lethargy, fever, and an increased salivation. You will see an increase in your eosinophils in the lab work, and they're very irritating the vein when you give them IV. That was the aminoglycosides. Macrolides, GI tract symptoms, so nausea, vomiting, abdominal pain. They can cause some diarrhea, loss of appetite, change in taste sensation, and photosensitivity, which can cause burns. Your tetracyclines, nausea, vomiting, diarrhea, sore tongue, rash, photosensitivity. They do cause yeast infections early in treatment. Lincosamides cause rash, pain, and redness at injection site and thrombophlebitis. Your oxalizinone can constrict blood vessels and increase blood pressure, cause nausea, diarrhea, and a headache. And your streptogramins can cause muscle and joint pain, rash, nausea, vomiting, pain, and inflammation at the IV site. When I did this chapter, I tried to break them up into category things because this was like fun. Now, adverse effects of the protein synthesis inhibitors, the aminoglycosides can cause very toxic to the ears, so you can have hearing loss, and it will decrease your kidney functions. Macrolide, the adverse effects interfere with many drugs of metabolism. It keeps many drugs in the system longer, causing side effects of that medication to stay in, especially like digoxin and Coumadin. When combined with other drugs, like mimazide, which is an antipsychotic, azenazoline with the antihistamine, terfenadine is the antihistamine, or ergotamine, to treat migraines. It can cause life-threatening cardiac dysrhythmias. It is very irritating to the vein and tissues, and it can cause liver problems. So we know that these medications, the biggest one out of those meds would be the digoxin and Coumadin, if I had to learn something, to know that it keeps it in the system longer, dig and Coumadin. The other ones I'm not too concerned about. Tetracycline can cause intracranial pressure, so it can increase pressure in the brain. And if you have an increased pressure in the brain, you know that causes dizziness, blurred vision, confusion, and tinnitus, which is ringing in the ear. High doses can decrease the kidney function and increase liver enzyme levels. Usually that will resolve after you finish taking the course of antibiotics. Lincosamides reduce liver function. They decrease white blood cell levels. If you give it too fast, you can cause shock or cardiac arrest. That's why it's important to always make sure you give the antibiotics as prescribed in the time frame. Oxazolinanones reduce red blood cells and platelets. It can cause damage to the optic nerve, and especially after it occurs if you take it longer than 28 days. You can have that optic nerve damage. And streptogramins increase blood levels of many drugs, so you have to be cautious with medications when you're taking streptogramins. So what do we do before we give any of these medications? Aminoglycosides, we're going to check lab work, especially BUN and creatinine levels, because it affects the kidneys. We're going to check the patient's hearing. We're going to make sure the IV, make sure it's diluted well, and we're going to give it slowly over 30 to 60 minutes. Macrolides, we're going to see if on certain meds because it can interfere with metabolism, especially digoxin, we said, and warfarin, Coumadin. And we're going to give that, infuse it slowly. Tetracycline, food, antacids, and dairy products prevent the oral form from being absorbed. So we want to make sure we give it 1 hour before or 2 hours after a meal. And don't give with milk. We want them to drink a full glass of water. So no milk with tetracycline. And make sure we don't take it with food. Lincosamides, check labs for BUN and creatinine levels because of the kidneys. It's very irritating to the veins and can cause phlebitis, and usually run it over 30 to 60 minutes. Oxazolinones, we're going to check labs again, BUN and creatinine levels because of the kidneys. IV vein irritation and phlebitis, and we're going to also give that one over 30 to 60 minutes. And streptogramins, check labs, BUN and creatinine levels, IV for vein irritation and phlebitis, and this one we also give over 30 to 60 minutes. And usually it's diluted with dextrose. And we flush the line with this dextrose after. So if you notice with these antibiotics, very bad for kidneys. Okay, so BUN and creatinine levels we need to check. Antibiotics are very, very toxic and very bad for the kidneys. So afterwards, we're going to be doing some things. If we're on the aminoglycosides, we're checking the hearing daily. We're checking for a fever. That's a side effect. Daily eyes and nose, we're checking the lab work. Notifying the doctor if levels of or increase of the BUN and creatinine. Macrolides, we're going to assess the heart rate and rhythm. Notify the doctor if the rhythm persists. Tetracycline, if the patient is on Coumadin, we're going to check for signs of bleeding. Lincosamides, check labs, BUN and creatinine levels. Oxazolinones, check blood pressure every shift because it can raise the blood pressure. We're going to check BUN and creatinine levels. And streptogramins, of course, we're checking those BUN and creatinine levels. We're going to teach the patients, if you're on the macrolides, to take with food or within 1 hour of eating to decrease GI issues. They do need to stay out of the sunlight, so they need to wear protective clothing and sunscreen to prevent burns. If they're on warfarin, which is Coumadin, they have to have blood clotting levels checked. They need to get that INR checked to make sure that they're within level, because that's very important. Erythromycin can increase the effects and increase the risk of bleeding. That's why we have to make sure we do those lab values more frequently. Tetracycline, drink full glass of water. Don't take oral form with milk. Don't take with food. So take 1 hour before or 2 hours after a meal. Stay out of the sun because you can burn with this. So you have to wear sunscreen and protective clothing. Lincosamides, also drink with a full glass of water, and encourage to drink water throughout the day because it will cause irritation to the esophagus. So water is very important for these. Oxazolinones, we're going to monitor the blood pressure because we know it can increase blood pressure, and we're going to avoid food that contains tyramine, and that tyramine will increase blood pressure because it is contained with a lot of salt. So it's all your aged things. Anything that is aged, like aged cheese, smoked meats, pickled food, beer, red wine, soy sauce, sauerkraut, anything that contains a lot of salt and it's aged, that is tyramine, and that we know salt can increase blood pressure. That's why we don't want to take any oxazolinones with tyramine. So for the pediatric population, aminoglycosides can cause severe respiratory depression in infants and children, and we have to watch for kidney damage because remember the kidneys are not mature. And tetracycline, this is important for tetracycline. During tooth development, it can cause permanent staining of teeth and makes the enamel thinner. Shouldn't give if younger than 8. Exception is if they were exposed to anthrax, and that is usually the drug of choice to give. But we should not give tetracycline to anybody younger than 8 because of the permanent staining of teeth, and it makes the enamel very thin. Now, pregnant or breastfeeding population, aminoglycosides can cause birth defects or fetal harm. It's not recommended to give, and you shouldn't breastfeed because it can actually cause hearing loss and decrease kidney functions. Macrolides can be taken during pregnancy. Med does pass through the breast milk. It can cause colic or diarrhea. So we do recommend not breastfeeding while on the medication. And tetracycline is definitely not recommended given during pregnancy. If used during the last half of pregnancy, it can cause the tooth discoloration and enamel thinning in the fetus, so it's not recommended to breastfeed, and you may have to take only if you were exposed to anthrax. In our older population, aminoglycosides are very ototoxic and nephrotoxic with high doses. Doses and on for many days, they may have to make a smaller dose to give them if they're on it for many days. And macrolides are very ototoxic if they're on furosemide, which is Lasix, which is a loop diuretic. We're going to report if they have any decreased hearing or tinnitus, and we need to watch their kidney functions by monitoring their intake and output and have them doing BUN and creatinine levels. So that is our second protein synthesis inhibitor drugs. Now the third one is our metabolism inhibitors. And there's two types of sulfonamides and trimethoprim. These are bacteriostatic. They do treat urinary tract infections, middle ear infections, pneumonia, infectious diarrhea. And you can see those on page 130. Okay, but like I said, two types are sulfonamides and trimethoprim. They're bacteriostatic. They come in creams, lotion, eye drops, and ointments. They do treat skin infections, vaginal infections, also in the perineum infections. Side effects: sulfonamides can cause headache, fever, rash, and sensitivity to the sun. Anything with sulfa causes sensitivity to the sun. Trimethoprim can cause a headache, nausea, vomiting, and itchiness. Adverse effects: sulfonamides. Very important with sulfonamides. They turn into crystals and they can form crystal-formed clumps in the kidneys, which will lead in turn to kidney failure and kidney stones. That is a big adverse effect for sulfonamides. It can cause crystallizations in the kidney and cause these clumps, which can cause failure and sometimes kidney stones. So that's a big thing with sulfonamides. Any sulfa drugs, sulfonamides. Metabolism inhibitors, they will suppress, these metabolism inhibitors, suppression of the bone marrow. So we know if it suppresses the bone marrow, it's going to decrease red blood cells, white blood cells, and platelets. These meds can also cause Stevie-J syndrome, Stevens-Johnson syndrome, which can actually kill someone and deplete their electrolytes because of the blistering of the skin. So that's bad. And we need to monitor our African American or our Mediterranean males who have a genetic disorder, G6PD, which is glucose 6 phosphate dehydrogenase. We need to watch them closely because they are at higher risk for anemia or being jaundiced. So before we give these medications, we need to ask them if they're allergic to sulfa because it contains sulfa. We have to ask our African Americans or Mediterranean males if they have any genetic blood disorders. We need to check their liver function tests because it's going to affect the liver, because we know with these it can cause anemia or jaundice. So we need to check for jaundice because it's irritating to the liver. We're going to check the CBC, so we need to check the red blood cells, white blood cells, and platelets because we know that an adverse effect is that it will cause bone marrow suppression, and that will decrease those levels, so we have to watch for that. We're looking for any skin bruising because we know with decreased platelets it can cause skin bruising. And very important to drink a full glass of water so we can prevent the crystal formings in the kidneys. They usually recommend having them drink water throughout the day. Elderly population taking a thiazide diuretic, it can increase the risk for bleeding and anemia. So that thing. And we do have IV trimethoprim, and it's a combination trimethoprim and sulfamethoxazole. It is very irritating to the tissue, and it's only to be mixed with D5 and water, and you flush it after with that, but you never give it IM, and it's always infused over 60 to 90 minutes. And I won't ask you time frames like how long you have to run the antibiotics. That you can find out when you give it. You can look it up. So what are we going to do after we give these meds? We're always going to make sure we drink fluids to prevent the crystals in the kidneys. We're going to recheck the blood work because we know it causes bone marrow suppression, and it also affects the liver, so we're going to make sure we check those as well as the kidneys. We're going to check for skin issues like blisters, skin problems, bruising, or jaundice. That's very important. We're going to teach our patients about these meds to protect themselves from the sun, and because they're at high risk for burns. We're going to tell them drink lots and lots and lots of water throughout the day to prevent the crystals forming. We're going to report ASAP signs of jaundice, any sore throat, fever, rash, blisters, or bruising. The pediatric population is not recommended for infants younger than 2 months because of the risk of causing jaundice. And pregnant breastfeeding population shouldn't be given the last 2 months of pregnancy because it can cause jaundice in the baby, and shouldn't breastfeed because of the jaundice issues. In our older population, there are risks for anemia and bleeding for people above the age of 65 years old, and bleeding will increase if they're on a thiazide diuretic. So that is our third category. Now, our fourth one is our DNA synthesis inhibitors. These are fluoroquinolones. Now, with our fluoroquinolones, think of fluoro, I think water. When I think of fluoroquinolones, I think of water. And that's going to help you with these, but the DNA synthesis. So these ones work on the DNA part of the bacteria. So our fluoroquinolones are used to treat skin infections. We use them a lot for UTIs, respiratory tract infections, infectious diarrhea, gonorrhea, and anthrax. They're very bactericidal. And on page 132, let me get on 132, are examples of our fluoroquinolones. And the biggest one, like I said, these ones end in fluoxetine. So your fluoroquinolones end in fluoxetine. So if you see it, we have ciprofloxacin, which is Cipro. That's a big one we use. And we use moxifloxacin, which is Avalox. Those are the two that I mostly give a lot in the emergency room, and I see a lot being used. The side effects for them, you can see them on the following page, and those are the ones you want to focus on, the ones on the box. They do cause rash. They can cause nausea and vomiting, abdominal pain, and muscle or joint pain. These ones concentrate in the urine, which can irritate the skin. So a lot of times when people urinate, they will say they're having pain with urination and to the surrounding tissues. So they will say, oh, my skin's burning. Whenever I pee, it burns around the skin. That's just because it's concentrating in the urine. That's why we tell them to drink lots and lots and lots of water when they're on fluoroquinolones, as well as the sulfa drugs too, but fluoroquinolones. Adverse effects for these drugs: heart dysrhythmias, especially if you're on other cardiac drugs, or heart irregularities, or hypokalemia. Also, it can cause peripheral neuropathy. So we can have that numbness in the legs or arms. It can cause hypo or hyperglycemia. So if you're diabetic, you need to check your blood sugars more frequently. And the biggest thing with this is it causes, the rarest, but it can happen, is rupture of the tendon. So your fluoroquinolones can cause tendon rupture, and that can happen in the shoulder, the hand, the wrist, or heel. So it happens more in our elderly population, or especially more if they're on corticosteroids. So if they're complaining of any wrist pain, elbow pain, heel pain, and they're on fluoroquinolones, they could have a tendon rupture, which we have to be very cautious with. So I know that's an important thing, as well as the diabetes and that. So what do we do before we give? We're going to give at least 2 hours before or 4 hours after taking an iron, multivitamin, or antacid. So you have to give the med 2 hours before or 4 hours after iron, multivitamin, or antacid. They need to take this pill with a full glass of water, and they need to drink water throughout the day, just due to the fact that it's, we don't want to cause those crystal formations. Afterwards, we're always assessing the heart. We're going to teach our patients, if you're on warfarin, we need to get those levels checked to make sure that everything's okay. It will increase warfarin's effect. A full glass of water, because it will irritate the private regions, that irritation. So we do not want to do that. So lots and lots of water to prevent that private region irritation. And tell the doctor, because if you have any pain in your for the tendon areas, you may have to put the med, because we do not want to increase your risk for rupture. Avoid the sun. It's not very good for the sun to be on fluoroquinolones and out there, because it could cause burn. Not recommended for the pediatric population under the age of 18, and the pregnancy population is not recommended for also. Now, our older population, we're going to see more of the tendon ruptures. Even though it's rare, it happens more in the older population. And so those are some things that we really have to watch for with them. Now, the next thing we have is the antibiotic drug resistance. And this is the ability of a bacteria to resist an antibiotic. It could happen due to using the med frequency or frequently or improperly. And this is due because a lot of people think that because they're sick, they need an antibiotic. And a lot of time it is just a viral infection and not a bacterial infection. And with viruses, we're going to be talking about that. It's a totally different treatment. A lot of times you just have to let its course run. But with a bacterial infection, that is when you need to take an antibiotic. But a lot of people think that because I'm sick, oh, it's a bacterial, I need an antibiotic. No, that's not the case. And because of that, that is why we're getting these antibiotic drug resistant drugs. It's because of overuse. Sometimes we give the wrong drug for the treatment. So the antibiotic resistance, it's bacteria can resist the antibiotic. It makes the organism susceptible so they can kill, so they can't be killed by the antibiotic. It resists it. And then more than 3 antibiotics, you can get a superbug and it can cause multiple drug resistant organisms. And those are the things we're seeing now, like VRE, MRSA, CRE. So that's why it's very important for people to realize that when they are when they're sick, they don't always need an antibiotic. The majority of the time, it's a viral infection that something has to take its course. But that is, like I said, that's a lot of information in this chapter about antibiotics. But try to break it up into terms like we broke it up as we go, and do it however way you have to. But remember, you don't have to know what diseases are going to be killed by them. You don't need to know how fast to run it, because like I said, you'll know that when you start running medications, a lot of times it will tell you. You can look it up and it will tell you how long you should run it. And a lot of your places do have policies of how fast you should run medication. But this is a very important chapter and a lot of information. And like I said, we will go over this if, even when tutoring before it, so we can get more into it and I can show you guys some ways of how to remember things. But go into it, remember the important things like drinking the water, like fluoroquinolones causes the burning, and if you drink a lot of water, that's going to help. Sulfa and the crystal formations in the kidneys, drink a lot of water. So those are some things to try to help you guys. But I will see you guys and call me for anything.